Hi, welcome to Skin and Wound Care. So we're going to overview some expectations for the Med-Surg unit. So let's go on. Now you're going to see this icon a lot. This means essentially that we are a team. I know that you guys all know that, and you do a great job in being a team. So we're going to talk more about how we function as a team with regard to wound care, wound assessment, and ensuring that our patients are as safe um, as possible while they're within our organization. You'll also notice, I'm going to click to the next slide. If you notice on the right hand side, there is a really fancy, just kind of like star, pow. That indicates the individual who is responsible for aspects that we'll be talking about. So we're going to begin with assessment on admission. Now, when we think about when does this need to be done, that's super easy. It must be completed within 4 hours of admission. So this is our Braden risk assessment, and it's going to then fall into a full head to toe. Um, Exclamation point, higher the Braden score, the higher the concern. And we need to identify that we have implemented interventions to prevent breakdown. So the RN is responsible for the initial Braden risk assessment, and our assessment on admission, we need to do a physical pat down and visualize and inspect all bony prominences. You want to say what you saw, not what you think or what you hoped. So if you say that there's no injury, that means that your eyeballs assessed no injury. Otherwise, and I'm really sorry to say this, you're lying. And I mean, I don't know how to put it any other way. If you just say that there's no injury and you haven't taken a look, that's fraudulent and that's wrong. So please don't do it. Um, so if you don't assess it, if you can assess it, um, write a note, put in a little comment, say that you were not able to assess at this time. And sometimes patients won't get up or won't roll over or they decline. Write that too. Say unable to assess, patient declined at this time. Now, why are there two individuals who are responsible? The RN is responsible for assessment within 4 hours of the skin, visualization of the skin, but our LNA colleagues, you guys are the ones who bring our patients to the bathroom. You're the ones who really see what they have going on. So what a wonderful partnership, right? So if you see something, grab your RN, grab your LPN, and bring them in and say, you know what, I've seen something, right on their hip. I've seen, their heels don't look right or their sacrum doesn't look right. So please come on and assess that. And that would be your nursing partner. Now the first initial assessment on admission would be that RN. Now pressure injury points. Now this is you see in the icon on the lower left. It's our everyone's responsibility to visualize pressure points and possible injury points. So heels, take those socks off. Don't take the word of an individual. Take those socks off, look at the heels, assess whether or not there's blanchable skin, check their sacrum, check the bony prominences of their spine, their elbows, their scapula, the back of their head. If they're lying on their side a lot, their ears, right? The ribs, the iliac crest, the malleolus. That's a really great point because sometimes we don't assess that piece. Um, and if the person's been lying on their side for a while, that is something to assess. I am going to mention, and I'll mention again, if we are worried or concerned that the person is not moving enough on their own, we need to implement a turning schedule, and that will be mentioned also further on. We need to assess devices that cause pressure injury. Again, on the right lower, you'll see it's an LNA, RN, and LPN's job. It's all of our job to keep our patients safe. So IVs, will cause pressure injury. Oxygen, not only a mask, but oxygen tubing, the back of the ears, our nasogastric tube. Think about if you've got pressure along that nares, that's going to split open that nose. And we want to watch early detection. Is there redness? Have we moved that line? Now, Foley's you can move from one leg to another and redistribute that pressure, because if you don't redistribute that pressure with Foley catheters, you will end up with a pressure injury. And with individuals with male genitalia, that will flay the penis. And if you've never seen a flayed penis, please Google that, because that's one of the most horrific things, and preventable things. So pressure injuries are preventable. I think that's one of the scariest things. Pressure injuries, and I'm going to keep repeating this, are preventable. Casts, devices. We have our C-collar here. We always want to look and are there pressure injuries? Are we at risk, right? Are we doing prevention? Are we putting barriers? One of the things also is the Masimo probe. If that's really tight on someone who has peripheral vascular disease and reduced perfusion, that can cause a pressure injury. So change those Masimo sites, rotate fingers, prevent pressure injury. Now, if with pressure wounds, if you did find something, right? And then this is on initial assessment. So that's where we see who's responsible. It's the RN who's responsible for that initial assessment. If you find something, say you found something, identify it as an existing injury. Because then we can start from, that moment going forward to be able to say, no, you know what, that person came in with a pressure injury and we're going to do something about it. And if you didn't find anything, no injury. And now going forward, how do we prevent that injury? So if it's on assessment, say you found it. And when you have identified that on admission, select the location of the pressure wound. So you identify the location, indicate that it was present on admission, and for staging, get a double check, because a lot of individuals have challenges with pressure staging. So get a friend, get one of the wound care nurses that and ask for assistance in staging. Because one of the things I just want to mention, I'm going to take another step back and just talk about pressure wounds again. One of the things with pressure wounds is they don't go back. They only, so you don't have a stage 4 and then have a stage 1. So I'm going to talk a little bit more about that in a second. When you do identify a wound, do an assessment and do some measurements. Now, it is all of our responsibilities to identify and to bring that to the forefront and document it. Now, my LNA colleagues, if you see something, right, bring your RN and your LPN in, because this is ongoing. This is not just during the first initial skin assessment, but it's every day, every 8 to 12 hours thereafter. So if you find something, say, hey, my RN buddy, I found something. And then your RN buddy or your LPN buddy, they're going to come in, they're going to take a picture, they're going to measure it. So when you take a picture, do it with the patient's name, so their little sticker, and measuring device, so a cotton swab. Measure it. So when you're measuring it, the length is 12 to 6, so the head to the feet, and then width is 9 to 3, or the hip bone to the hip bone. So when you are utilizing length and width, that's how you measure it. When you measure wounds on the feet, imagine a ballerina standing on her tiptoes. So heels would be 12 o'clock, toes would be 6 o'clock, and that would be length, and from big toe to little toe, that's width. So first and foremost, I really do need to emphasize that we need wound care orders. So when we do have a wound that needs something more than just Mepilex, or something more than just a gauze and some tape, we need to have identified wound care orders, and I'll go over what needs to be included in those wound care orders. If we do not have wound care orders, then we're going rogue. As LPNs and RNs, we do need to have something that assists us and guides us in the care of that wound. We can't just determine what type of packing or primary dressing we're going to use because we think that might be good. So contact your wound care nurse or the wound care team to be able to help you with that if you find that you do not have wound care orders that match your patient's need. Label your dressings with your initials, date, and time, and I'll re-emphasize this in another slide. Anytime there's something placed on a patient, it needs to have the date, the time, and initials. Measurements of wounds are every Sunday. Pictures are also taken on every Sunday to evaluate healing, and anytime there is a change, like increased drainage, it looks like the wound is getting worse. Anytime that you've identified there's a change, take a picture. Wound pictures in the avatar. So again, this emphasizes every Sunday RN takes, or the LPN takes, the picture, and the RN then assesses the wound reassessment. And that's an RN LPN buddy system. So that way we can all be involved as a team. Now, if there's anytime there is a break between wounds, consider it a new wound. So it's not like the whole left leg has, and you have a series of 5 or 6 open areas. That's not considered one wound. It's 5 or 6 open wounds, and you need to identify those on the avatar. The wound pictures in the avatar continued. Select the image that you just took and link it to the site. When you take the picture, please write a brief description, because then that assists in saving that picture into EDH. If you have any questions or challenges in taking pictures, please ask your charge nurse or a colleague or the wound care team to help you in taking those pictures if you're having trouble or difficulty doing that. Pressure wounds, again, please don't stage the pressure wound until you have it confirmed, because this is the patient's chart, and we want to be as accurate as possible. And as I was mentioning, it never goes backwards. If it's a stage 3, then as it heals, it is a healing stage 3. It is not suddenly a stage 2 and then a stage 1. Now, if you do have a stage 1, it can get worse. So a stage 1 can evolve into a stage 3, and then it stays there as it heals. And the image on the right is stage 1 to stage 4. A stage 1 is unbroken but inflamed, unblanchable skins, right? So when you place pressure there and let it off, you do not see a white indentation of your the pressure, and then as you lift up, the area then is perfused, so it's unblanchable. Stage 2, skin is broken to epidermis or dermis, or there is a blister. Stage 3, ulcer extends to subcutaneous fat layer. Stage 4, undermining is possible in a stage 4. Ulcer extends to muscle or bone. There is also an unstageable, which looks like a bruise. If you have any questions, please consult a colleague before staging. Patients sitting up in a chair. Reduce sitting time to 2 hours. Have them move every 15 minutes. So this is where our LPNs, our LNAs, our RNs. This is a collaborative effort. We all need to get together and talk about how we're going to help facilitate reducing pressure. So have them move or jiggle, redistribute their weight, get up and go to the bathroom. Walk, even if it's, to the door and then back. That increases perfusion, that reduces pressure. If they do have a stage 1 or greater on their coccyx, time in the chair needs to be reduced to less than 1 hour. Just think about time is tissue. And once we need to be proactive in preventative measures, but once we've identified a pressure wound, we do then need to consult with our provider, and we need to consult with the wound care team to come up with further interventions. When we're thinking about further reducing pressure, we need to be very careful about pressure reducing devices. Donuts are not advised. So please, if you are considering a donut, please know that these are not advised. This is not part of the evidence currently, and include your wound care team on any concerns or thoughts or ideas on how to reduce pressure. Now, some options: offloading pressure. You have your boots. You also have your gel seat cushions. These are really good in reducing pressure. And we can talk to our PT and OT team on what can we get to help be able to assist our patients in reducing pressure, and either utilizing that as an intervention for a stageable pressure wound or as a preventable intervention. Now, when we think about how do we prevent or how do we treat, we need to make sure that we are turning and repositioning our patients. We need to talk as a team, our LNAs, LPNs, RNs, together. What is our turning schedule? Because that way we can all be in on the plan and to be able to affect change and help our patients. We need to offload pressure on the heels. We need to have either them elevated, or like with a pillow with the knee supported, so that way the knee is not hyperextended, or we need to have some sort of uh, dressing on it, as you can see on the right upper hand of the screen. And look at that, there was a date and a time. Now the date is way out. I mean, like, so way out. That dressing needs to come off. So we need to make sure that our dressings are appropriately dated and appropriately changed. There's a difference between preventative, which can stay up on a patient for up to 7 days. And what we need to do is take down that dressing, assess underneath the, because we don't want any surprises. No surprises. Remember, the only surprises we do like are chocolate and coffee and really bad dad jokes. We do not want surprises like, oh, look at you. This was actually meant to be prophylactic, and now you have a stage 2. So we always want to take down our dressings and assess what's underneath. You want to document all interventions and if the patient declines or refuses. So remember, if it's not documented, it's not done. Now, I do want to talk about wounds, because if a patient comes with wounds, we now have the option, just as like we have the option for present on admission for pressure wounds, we have present on admission for wounds, regular wounds. So we have lots of option. Now, and here's where it's a team effort. If the patient declines movement, then we need to make sure that we document it. And we need to make sure that we document if we've moved them and when, right? If we are on a schedule of Q2 hours, which the literature currently suggests that Q2 hours was subjective timing to be able to start interventions. Everyone's different. Like if I moved every 2 hours, I think my ear would fall off if I was laying on my side. Think about when you're laying in bed. Do you like stay there all 2 hours? No. Sometimes you're flipping and you're flopping. Some people might be there 2 hours. It depends on your body. It depends on your bed. So think about who's this person? What do they have for nutritional supplementation? What do they have for reserves? And is Q 2 hours too long or is it just right? Now, chart positioning or refusal. And when you're thinking that you may need a wound consult, here are some possible triggers: a new or changing wound, a suspected pressure wound, high Braden score. Just to like, hey, I'm really thinking about implementing these interventions. Our care plan has great interventions for high Braden scores. Sometimes we do need to initiate that ourselves. So please take a look in the care plan section of the patient's chart. If you have any questions, Randy McSwain, Amanda Fay, that's me, are wound care certified. We're hoping to get some more individuals wound care certified, so please give a holler. On nights, that would be swell, Monday through Friday. And if you do have some concerns, email us with the patient's MRN number, concern, or assessment, and then the wound care team will then evaluate and triage. For complex wounds, the wound care team will write orders. Simple wounds, discuss with the provider. Now, also include the charge nurses because Randy or myself may be off the floor or involved in other events or activities off the floor. Weekends, charge nurses will provide first reviews, so please do not wait if you have any questions. Your charge nurse is always a great resource. Wound care orders, when you have them, and you must have them, right? There is always a must. You must have them. Otherwise, you're going rogue, and if something bad happens, then you need to take accountability for the things that you do and you had no order for. And that really is unfortunate. Don't do that. So you need orders. For a comprehensive treatment order that will promote consistent care, it should include all of the following: the wound location that the wound order is for, cleansing solution used to clean the wound, primary dressing to be applied to the wound bed, as needed a moisture barrier for the peri-wound skin to prevent maceration and breakdown, as needed a secondary dressing to be placed over the primary one, um, as needed secure with, is it tape? Is it a gauze tube? So you need to have identified what is it the dressing is going to be secured with. Frequency of dressing changes. So the provider and the wound care team will either follow manufacturer guidelines or they will be written to change more often based on exudate amount or strike through, which is exudate amount, and expected duration of need. Now, if you have reviewed and identified that um, after a week of utilizing this type of wound care and there has not been any improvement, readdress with the provider and the wound care team, because our goals together are to help increase our patients' care. Now, skin rounds. RNs, an RN and an LNA will be reviewing all of the patients on the floor weekly. It will be a full head-to-toe assessment for skin down, pressure risk, pressure wounds, etc. And this will be done for the upcoming foreseeable future. So please be aware that this will be done weekly, and that will be determined by the individual who will be doing the skin round. Look for dressings that are not labeled. They'll be making recommendations wound care if wounds are identified. So they'll be bringing the primary nurse in on this care, reviewing admission documentation for comprehensive assessment and identification of wounds. They'll also be talking with the LPN, RN, and LNA team about next steps for interventions for either prevention or treatment. So if you have any questions, and you're wondering how do you learn more, just give a holler. We've got this. It's about working together, um, and providing the interventions that we know are the best and most evidence-based treatment for our patients, because that's what we're there for, right? We're there for our patients. And if you have any questions, give a holler.